Postoperative care. The postoperative period will begin when the client is admitted to the post-anesthesia care unit, also known as PACU or the recovery room. This room is located near the operating room, and this will enable the surgical and anesthesia personnel to be readily available for any emergencies. The anesthesia personnel and circulating nurse will be the ones who transport the client from the operating room table to PACU. And then the anesthesia personnel will stay with the client until they are assured that the client has a good airway and overall is stable. So initially, when the client gets into the PACU, that PACU nurse is going to assist with transferring the client from the gurney to the surgical cart or the PACU cart. They're going to be attaching them to the vitals machine, putting them on the heart monitor, making sure that oxygen continues if necessary, making sure the IV is going, etc., etc. So we'll also be looking at the surgical site. They're observing for vascular issues. Clients are usually pretty cold when they come out of the OR because remember, they keep it at 70 degrees in there. Making sure the client is positioned appropriately to protect the incision and the drains, keep that airway open, and also assessing for orthostatic hypotension. The PACU nurses are very knowledgeable in their ability to care for the clients recovering from anesthesia. That initial post-op nursing management is going to kind of follow that Aldrich scale. We're also looking at airway patency. Are their respirations effective? Are they oxygenating the body well? Do they have artificial airways in place or mechanical ventilation? What is their oxygen level at? And are they receiving supplemental oxygen? We look at the circulatory status. That includes the blood pressure and the heart rate. Looking at the condition of the wound. Is it covered? Are we seeing anything abnormal? Looking at the dressing. Is there any drainage that is shadowing on the lower parts of the dressing? Is it dry and intact, or is it saturated and we see frank bleeding? And if they have a drain, what does the contents of the drain look like? Is it straight blood? Is it straight serous drainage, etc.? What is the client's fluid balance? And this requires us to look at the IV fluids and the fluid rate. Do they have an indwelling urinary catheter? And if they have a drain, how much is coming out of that drain? Is it an amount that's acceptable? What is their level of consciousness? Are they laying there looking around, or are they dozing when they're not being directly spoken to? What is their pain level? And then the nurse also monitors for any potential complications. There's a tool that we use that is going to help us determine if the client is ready to be discharged from PACU. Now, each facility will have different requirements as to what the score should be prior to discharge from PACU, but we look at basically the same things. We're basically determining how the client's recovering from anesthesia, looking at their mobility, their respirations, their blood pressure, level of consciousness, and pulse oximetry. Now, this is a copy of an Aldrich tool. They're all just a little bit different, but as you can see with activity, we're looking at movement. How many extremities can they move? But understand if they had a regional anesthesia, such as a spinal anesthesia, they may not be able to move their legs for a few hours. So that may receive a lower score until later in the day. Looking at their respiratory status, how deeply are they breathing? Is it just shallow? Are they having dyspnea? Or are they not breathing on their own at all? We're also looking at their circulatory status. We're looking at their blood pressure and determining if it's within appropriate levels. For example, if a client had a blood pressure of 110 over 80 pre-operatively, then we're comparing their pressure post-operatively in PACU with that pressure. So it can be 20 millimeters of mercury above or below the original setting. So for the systolic, we said 110, so it can be as high as 130, but it could be as low as 90 and still be acceptable. And with the diastolic, we said 80, so it could be as low as 60 and as high as 100 and still be within the acceptable ranges for them to receive the highest score. We also are going to be looking at their level of consciousness. Are they just laying there, maybe eating some ice chips or sipping on some water, talking to the nurse whenever the nurse is available? Are they dozing while they're not being disturbed? Or are they just not arousable? And then we look at the oxygen saturation. We would like it to be at least 92% without oxygen, but it may be that they need oxygen to maintain that 92%. So we're scoring according to the assessment findings. So different postoperative complications. We may see hemorrhage. That PACU nurse is going to assess for symptoms of shock. They're going to be looking at the blood pressure, the heart rate, the respiratory rate, inspecting the dressings, looking to see if there is any frank bleeding going on. And always remember that one of the areas where we assess for bleeding is going to actually be underneath the client. Think of gravity. The blood may travel underneath the client and may not even be visible on the dressing itself, except around the very edges. So always use a gloved hand and gently slide it under the client to determine if there's any blood there. We're also going to continue or initiate any blood transfusions if they have been ordered. If there is bleeding, we reinforce that dressing and definitely monitor wound drains. We don't want too much drainage coming out of those drains. For shock, we're going to suspect there is fluid and electrolyte loss. Can also be from trauma or the anesthetics. Any of the medications they receive during surgery or PACU period that can contribute to shock. We treat shock with blood or plasma expanders, IV fluids, oxygen, and potentially some medications. Hypoxia. This can be due from residual drug effects, the client's pain level, the position they're lying in. Maybe there's pooling of secretions in the back of their throat, or an obstructed airway. Their head is tipped forward and it's completely blocking off the airway. We treat it with oxygen and potentially suctioning to remove secretions, and definitely assess for signs of cyanosis and dyspnea. Aspiration is another potential complication. That aspiration can be from something as simple as saliva. It can be from mucus, those secretions that gather in the client's throat. It can be from vomitus or blood. This can all happen until the client is awake and that swallowing reflex has returned. It's important to have suction equipment available at the bedside that as we are administering ice chips or sips of fluids to the client, that we're assessing the client's ability to swallow. We may need to put the clients in a side-lying position to help prevent aspiration. Excuse me. Wound dehiscence is going to be a separation of the wound edges without protrusion of the organs, and that's what you see in the picture in your slide. It's likely to occur within 7 to 10 days post-operatively if it's going to. Risks for dehiscence include poor nutrition, chronic disease, older adult, increased abdominal tension, obesity, and infection. So it's really important as nurses to decrease the strain on the incision and notify the surgeon. Typically, if we have a dehiscence, we do not reclose the wound. We will just now begin to pack it. So we pack the dressing inside the open wound and we let it heal from the inside out. Evisceration is basically a dehiscence, but now we do have protrusion of the organs. If we have a client who eviscerates, we cover it with a sterile dressing and moisten it with normal saline and notify the surgeon. And of course, these clients need to be put back into bed immediately. They will have to go back to surgery. A paralytic ileus is paralyzed intestines with no peristaltic activity. This may require a nasogastric tube, and clients are on an NPO status until bowel sounds return. Now understand that anesthesia can slow down and or temporarily stop the peristaltic activity. But be aware that this should slowly improve through the first 24 to 48 hours. So it's not abnormal to hear very hypoactive bowel sounds the first day postoperatively and maybe a little better on the second day. But by the third day, they should be much, much better. And we'll talk about the best thing to do for that as we move along. Pneumonia and atelectasis. Atelectasis is known as the collapse of alveoli. These are possibly due to drug effects or a failure of the client to take those nice deep breaths and immobility. The older adult is going to be most at risk for these complications. In addition to the client who is obese, clients that have been diagnosed with COPD, or clients that had chest or abdominal surgery. They're not going to want to take those deep breaths for the simple fact that it hurts. Infection is going to be the next complication, and it's indicated by increased wound pain or drainage, erythema, increased warmth, and purulent exudate. There is an increased body temperature that in this client may require antibiotics. Infection risk will be increased with traumatic wounds, wounds that were not treated promptly, or wounds that were infected preoperatively, in addition to clients that are obese, immunosuppressed, or have a diagnosis of diabetes mellitus. Why would diabetes increase our risk for infection? Well, these clients have a high glucose level, sugar. Sugar feeds bacteria. So bacteria loves these diabetic clients. And thrombophlebitis is the inflammation of veins with the formation of blood clots, usually caused by long periods of immobility. These clients are at an increased risk for pulmonary emboli. We're going to put the anti-embolism stockings or the SCDs, the sequential compression devices, on these clients to help improve the blood flow going through the legs and reduce the risk of blood clot formation. So later in the postoperative nursing period, this begins when the client arrives to the client's hospital room or the post-surgical care unit. Assessment is going to include the same things that the PACU nurse assessed, but it starts all over again now with the postoperative nurse. This will include the respiratory status, the circulation, the pain level, fluids, nutrition, skin integrity, wound healing activity, bowel elimination, urinary elimination, and psychosocial status. But remember, when we're talking priorities, ABC, airway, breathing, circulation. So it's going to be are they breathing? What is their respiratory rate? What is their oxygen saturation? Are they struggling to breathe? We're also looking at circulation. What is their heart rate? What is their blood pressure? What does their skin color look like? Then we can look at pain level and safety and changes in level of consciousness. So the nurse should assess the respiratory and cardiac function, general condition, their vital signs, their fluid status, pain level, elimination, and flatus. Nurses are kind of weird in that we love it when our clients tell us that, yes, I'm passing gas, or I had a bowel movement. We're also evaluating the dressing, any drains, and any IV lines. With the respiratory status, make sure that we're encouraging those deep breathing exercises, and that will be every hour while awake. We don't wake them up in the middle of the night, but we do encourage this to be done every hour during the morning and evening hours. We're also going to encourage the use of the incentive spirometer. Again, the incentive spirometer is a little plastic device that the client is going to suck in on to see what their lung capacity is. We want them to take those big, deep breaths. Nurses like measurements, and this will give us a good measurement to let us know if the client is improving, maintaining, or deteriorating. But some of these clients, especially some of your older clients or your clients that have a mental deficit, can't quite get that incentive spirometer to work right. So, most important thing is just have them take a nice big deep breath in, hold it for about 5 seconds, and then blow it out slow. And we do that 10 times. We also encourage splinting of the incision. So if they're having abdominal pain when they're trying to take these big deep breaths, take that pillow, take that folded blanket, and we lay that on their abdomen, have them pushing on it lightly to provide some support so now they can take those big deep breaths. If they do not take big deep breaths, we need to be assessing their pain level. Maybe they're hurting too much. We also need to educate them on the importance of these big, deep breaths. It's going to help prevent pneumonia. It's going to help prevent atelectasis. They will get to go home sooner. If we need to, we can provide supplemental oxygen as necessary, encourage frequent position changes, and early mobilization. This is going to be extremely important, not only for the respiratory status. Again, moving around mobilizes those secretions in the lungs. We want them to take some nice, good belly coughs, that type of cough, not the effort. So if they can do that, they're mobilizing those secretions and they will not be sitting there potentially growing bacteria. That early mobilization is not only going to help them now expand their diaphragm better to take those better breaths, but it's also going to improve their circulation. So it's going to help prevent the blood clots. It's going to help improve the peristaltic action of not only the bowel, but also of the bladder. So we expect to see improved bowel sounds and we expect to see improved urinary output if they've been having issues with those. We also know that early mobilization is ultimately going to help them with their pain level. So it's not going to be an immediate thing, but whereas they may have been having to take narcotic analgesics for 2 weeks, now they're only taking it for 1 and then supplementing with NSAIDs after that. So their pain level decreases faster or sooner than it would have without that early mobilization. And then finally, because of that improved circulation, that improved mobility, they're not only going to be passing gas faster, they're going to be having the bowel movement faster, they're going to prevent those respiratory complications, they're going to prevent those circulatory complications such as the DVTs. They're also going to heal faster. So they don't want to do this, but they need to be ambulating at least 4 times a day. If they struggle with this, then we do progressive ambulation. So the night of surgery, let's say they had a morning surgery, so by 4 p.m., 6 p.m., we're at least sitting them on the edge of the bed and dangling. And if they're able, then we'll get them up and walk them to the door or get them up and set them in the chair for 30 minutes. The next time they get up, then, okay, you walked to the door last time. Let's see if you can walk to the nurse's station after that or to the next room down the hallway and then back to your bed. So you progressively increase the amount of distance that they're going. The circulatory status is going to require assessment of the blood pressure, potential orthostatic hypotension, assessment for bleeding, and venous circulation impairment, again in the form of the DVTs, the thrombosis, which could potentially break off and become pulmonary emboli. Postoperative pain is going to be at its greatest 12 to 36 hours after the procedure. That pain should be treated before it becomes uncontrollable, because if we let it get uncontrollable, then it will take stronger pain medication and it will take longer for the pain medication to actually begin to work. So the nurse has to help monitor this pain level. If we can keep their pain under control, they're also more likely to do the deep breathing exercises, and more likely to ambulate, which ultimately is going to help their recovery period. So some of the medications that we may give are opioids. Opioids are going to be given for moderate to severe pain. We may also use it in conjunction with anesthetics, and it can be used to suppress the cough center. One of the major complications of opioids is going to be respiratory depression and constipation, in addition to potential for abuse. So make sure that you review your opioids. Make sure that you know that your opioid antagonist or your antidote for opioids is going to be naloxone. We're also going to be administering fluids and nutrition. This will be given IV initially, and dietary progression will be dependent on the type of surgery the client had, how well the client is progressing, the physician order, the client's nausea, vomiting, do they have an NG tube, which is frequently placed when a client has abdominal surgery. Guidelines for resuming oral fluids. Again, we keep the client's NPO until the bowel sounds have returned or gastrointestinal activity has resumed. They begin passing gas, they've had a bowel movement, etc. But remember that that activity may not return for 24 to 48 hours. We're also going to assess swallowing, making sure that that gag reflex has returned. We'll introduce sips of water or ice chips slowly, usually within 4 to 24 hours post-op, unless it was a gastrointestinal surgery. And sometimes they may go without anything by mouth. For 3 or 4 days before they're allowed anything by mouth if they've had a gastrointestinal surgery. It just depends on what the procedure was. We may administer antiemetic medications if the client is nauseous or they begin vomiting. And when able, once the client is able to take in a regular diet or a soft diet, we would promote protein, calories, vitamins A, C, and zinc for wound healing and immune system function. So then we also look at their skin integrity and their wound healing. We're assessing that wound. Do they have any devices such as drains to remove the fluids from the wounds? Drains might remove the fluid passively or actively with suction. There's 4 different types of drains that we're going to talk about. And the first one is a Penrose drain. A Penrose drain is a flat silicone type drain that is placed deep into a wound, and it lies flat on the skin outside the wound. And they often put a sterile safety pin in the portion of the drain outside the wound to prevent it from sliding back into the wound. And it just allows a place for drainage to come out of the wound. A Jackson Pratt JP or Reliavac drain would be a hollow silicone bulb that has a cap on it, and this cap will be where we can empty drainage. We empty it into a device to measure the amount of exudate coming out of it, and then that bulb is attached to a tube and it's placed near the wound through a stab site. The cap is open and the bulb is compressed. While holding that compression, then we replace that cap. The drain is often secured to the client with a suture. And then to keep tension from pulling on that insertion site, We often will safety pin that drain to the client's gown or dressing. Then the next type of drain is what we call a hemovac. This is basically a circular drum-shaped spring-loaded drain. It's maybe 8 inches in diameter, and like the JP, it has a cap on it, and we have the cap open. We compress the drain and then replace the cap. That drain may also be secured to the client with a suture, and it's a type of drain that can come with the option of reinfusing blood, and it would be the client's own blood. We typically see the hemovac drain with an orthopedic type surgery, such as a knee replacement or a hip replacement. Again, this drain usually has a clip on it, similar to the clip that you'll find on the indwelling urinary catheter tubings, and that's used to secure it to the bed or the client's clothing. Clients may also have a nasogastric tube inserted through one of the nares, and that would be attached to low intermittent suction. Those tubes are secured to the client's nose with adhesive to help keep it from coming out, and then we secure it to the client's gown to help prevent dislodgement. We always have intermittent suction because the suction is going to pull the holes of that tube up against the client's interior stomach or small intestine. And it can actually, if it's a continuous suction, it can actually suck wounds into that interior lining. So it should always be intermittent so it releases periodically. There is one other type of drain that I'm going to mention, and this is called a T-tube. A T-tube is a drain that is often placed when a client has a gallbladder removed, so they have a cholecystectomy, and it is designed to specifically drain bile. Clients often will go home with a T-tube, and it's removed at a later date. So as we're assessing the wound, don't forget that we are assessing the approximation of the wound edges, making sure that it's staying intact, that it's beginning to heal closed. We're looking at the intactness of the staples or sutures. We're looking for signs of infection and reactions to the adhesive or the dressing. A lot of people will react to adhesives, so we need to be very conscientious of formation of blisters, etc. Phases of wound healing will include that inflammatory stage. So, as it begins to heal, we expect there to be some light pinkness around the edges of the wound, some slight edema, maybe a little bit of drainage. We do expect there to be some pain. I mean, that's pretty normal, and it's going to be a little warmer than the rest of the body. However, if that begins to extend very far from the edges of the wound, becomes a darker red, becomes more painful, becomes more warm, etc., then we need to suspect there might be infection going on. Phases of that wound healing include that, again, inflammatory stage, the proliferative phase, and the maturation or remodeling phase. There's 3 different modes of wound healing. When we close a wound with sutures or staples, we call that well approximated, and it's healing by primary intention. If we leave the wound open, as I discussed with the dehiscence, the wound has opened up. We usually do not reclose that. We begin to pack it. So now it heals from the inside out. These clients will have a more significant scar, uh, but it will still completely heal. And then tertiary intention. We leave that wound open initially, and then we go back to suture the edges at a later date, usually 3 to 5 days later. Now, if we leave a wound open and we begin to pack that wound, it's usually because there was infection in the wound itself, whether it was from trauma, or let's say the client had a ruptured appendix. So now we have fecal contents that have leaked into the gut. That would definitely be a reason to leave that wound open to heal by secondary intention. So factors that affect the healing, we have impaired circulation, malnutrition, hyperglycemia, infection, foreign bodies in the wound itself, the client's age, and immobility. Signs of infection include increased incisional pain, redness, swelling, heat around that incision site, purulent drainage, fever, headache, and anorexia. Again, complications of wound infection excuse me, would be dehiscence and or evisceration. So in the postoperative period, we're also encouraging activity. We advance that activity as tolerated as soon as possible. And once again, we need to make sure that we're administering pain medication to ensure compliance. With regional anesthesia, initially their movement will be restricted until feeling returns. And again, spinal anesthesia, those clients need to remain flat for longer periods of time to help prevent and or treat spinal headaches if that is an issue. With bowel elimination, these clients may have some abdominal distension, and this could be caused by narcotics, their diet, and inactivity. We have to encourage them to ambulate and do those frequent position changes, and then appropriately um, advance their diet. And remember that paralytic ileus is the paralyzed intestines, and we may see acute gastric dilation in a stomach that's dilated with fluids. Some clients have difficulty peeing after surgery. If they're unable to void within 8 hours postoperatively, 8 hours, we encourage them to void, but it may require straight catheterization. So, we began encouraging them to void a few hours after surgery if they are not feeling that urge, making sure they're getting adequate fluids in, then maybe getting them up and walking to help encourage that peristaltic action. It's getting to hour 7 and they still haven't voided. I need you to get up and try. If you're unable to go within the next hour, then I'm going to have to insert a catheter to drain that urine. Most clients will be able to void uh, by the 8-hour time. Their psychosocial status needs to be considered because it may be alterated due to changes in body image or lifestyle. So always assess for issues and refer them for counseling or to support groups if need be. Gerontological considerations. Um, Remember that the older adult can develop confusion and disorientation with narcotic and barbiturate use, or the anesthesia. And this is what we call delirium. So respiratory depression is also going to be at a greater risk in the older adult with narcotics. We may have a delay in healing due to thinner skin and loss of subcutaneous tissue. And these older adults are at an increased risk for infection due to a diminished immune response. So which intervention would be indicated for a client with thrombophlebitis of the leg? Encourage fluids by mouth, gently massage the affected leg, keep the leg positioned below the level of the heart, start antibiotic therapy. We need to encourage fluids to ensure that the client is adequately hydrated. We know that with dehydration that it actually increases the risk and the thickness or the viscosity of the blood. So discharge teaching, excuse me, discharge instructions should always be verbal and in writing. Make sure that you are including the family in the teaching, at least one other person. The client may not be as alert and oriented or on task with teaching. So it really is important to include someone else. So determine the client's needs, and this includes their ability to perform self-care, their need for supervised home care. Do they need any supplies? Do they have any special dietary needs? Do adjustments need to be made to their living environment? And what about pain medication? Discharge instructions should also be reviewed with a responsible adult other than the client. Instructions should include medications, wound care, activity, including are they able to take a bath or a shower, or are they able to drive? What is their diet? When should the doctor be notified? Excuse me, and this should be for pain that is not controlled by their pain medications. If they start seeing symptoms of infection, then we know that the doctor needs to be notified. And they should also be encouraged to keep all their follow-up appointments. So understand when the client comes back from surgery, they get to their room, we don't necessarily have to pass on discharge instructions to the nurse at that point. This is one of those points that students often get wrong, so I'm trying to clarify. Discharge instructions, even though we work on discharge from the time of admission, don't have to be passed on from nurse to nurse to nurse. This is between the nurse and the client, or the client and the provider. And your post-test.